Good evening, everyone. Uh, Today we are going to talk about diabetes and cardiovascular disease. And I have the privilege of introducing today's speaker, Dr. Nitin Reddy. So before I tell about him, I just want to welcome all of you. Thanks for being here. So Dr. Nitin Reddy Mudugu is a consultant endocrinologist with strong academic background. After graduating with an MBBS degree from Kakatiya Medical College, he pursued an MD in general medicine and a DNB in endocrinology. He has experience working as senior resident and currently practices at AIG Hospitals, Gachibowli, Hyderabad. Dr. Nitin is actively involved in research, having co-investigated clinical trials and co-authored publications in esteemed journals with high impact factor and book chapters on various topics related to endocrinology and diabetes. His membership in professional societies like ISBMOR and Endocrine Society further highlights his commitment to the field. There's a lot of other things I would like to talk about Dr. Nitin Reddy, but in the interest of time, I would hand over the screen and mic to Dr. Reddy. So over to you, Dr. Nitin Reddy.
Yeah. So thanks for the kind words of introduction, sir. So can you please help me in sharing the slides back in team, please? Yes. So the topic for today's discussion is to understand the correlation between diabetes and the cardiovascular disease, and why is this deadly combination important, and how can we tackle this with the available options that we have in hand for the management of diabetes. Especially, we'll also discuss about the dapagliflozin in particular. Next slide, please. So yes, so this is the problem statement for diabetes in India. As we all know, diabetes and India is next only to China amongst the most populous nation, with people having type 2 diabetes mellitus patients. And if you can see here, it's clearly mentioned that 50% of the people doesn't even know that they are diabetic, because of the fact that majority of the type 2 diabetes mellitus, especially in the initial stages, it's practically asymptomatic condition. So that's the reason why the screening has a pivotal role in this context, especially all those people more than 40 years of age, and if they have the risk factors, especially in the form of past history of gestational diabetes mellitus, obesity, family history of diabetes mellitus, it's important especially to go at the screening for the diabetes in spite of the fact that they doesn't have any symptom. And the numbers say that the prevalence of diabetes in India as of now is close to 10%, and 90 million people in India as of now are living with diabetes, and the numbers are expected to rise. By the year 2045, it's expected to touch 120 million. So that's the number of people living with diabetes in India. Next slide, please. So here we shall discuss about the cardiovascular disease in particular in the context of type 2 diabetes mellitus. And this particular cardiovascular disease is the major reason for the mortality and the morbidity in patients with type 2 diabetes mellitus. And it's important to note that it's the coronary artery disease which is the leading etiology behind the mortality because of the cardiovascular disease, and then subsequently it's a heart failure. Next slide, please. And it's important that both diabetes as well as cardiovascular disease lead to the other condition and vice versa. Next slide. So here in this particular slide, we can see the bar diagram clearly showing the risk factors and its influence on the cardiovascular disease. If you see here, the BMI, the more is the BMI, the more is the risk. A person who has history of smoking, the risk for the cardiovascular disease is pretty much there. And with the age, the risk again further increases. But if you club these risk factors, the bar diagram where all the risk factors together, obesity, smoking history, age, and there we are at the top with the risk factor for cardiovascular disease. At the we can see number 5 bar in this particular left side of the cartoon. And to the right side, it says that both men as well as women are not spared from this cardiovascular condition. And if you see, the red line stands for women, especially the postmenopausal women. the risk of cardiovascular disease is relatively more in comparison to the men. Next slide, please. So, what leads to cardiovascular disease in diabetes? No, it's a multiple etiology put together. It's diabetes, the inflammatory markers, the oxidative stress, the advanced glycation and products, and all in all, the atherosclerosis leading to the plaque accumulation and the thrombus leading to the coronary artery disease. Next slide, please. So this again is the cartoon which demonstrate the pathogenesis of the cardiovascular disease in diabetes. So the cumulative of the genetic factors, phenotypic features, the obesity in particular, the other coexisting comorbidities, and the lifestyle of an individual, especially the smoking. Each and every factor is important. It's important to address all these risk factors in an attempt to prevent the future cardiovascular event from happening. So, gone are those days where we typically follow the glucocentric approach in the management of diabetes, and it should have to be we should have to approach the patient in total. It's important to think in terms of weight and other comorbidities before we go ahead with choosing the right option for the management of diabetes. Next slide, please. So again, what can we do for the prevention of cardiovascular disease? As we all know, the primary prevention is where we are addressing the risk factors for the cardiovascular disease even before the cardiovascular disease is sets in. And secondary prevention is when we are preventing the future cardiovascular event from happening in an already established cardiovascular disease. So yes, we have options which can manage both or prevent the primary event from happening and also the secondary event from happening with wonderful molecules, especially the GLP-1 group of drugs as well as the SGLT2 inhibitor group of drugs. And we'll be discussing about one particular molecule, the dapagliflozin, in the next coming few slides. Next slide, please. And we should have to prevent we should have to address the lifestyle changes, especially prevent smoking, and should have to adhere to the healthy lifestyle. Physical fitness is also pretty important. And the therapeutic strategies, especially we have DPP4 group of drugs, SGLT2 and GLP1 group of drugs, and these are all the novel group of drugs. But especially we have robust evidence with the SGLT2 group of drugs in an attempt to prevent or tackle the cardiovascular disease in diabetes. So early initiation of the combination therapy is particularly important, especially with the verify trial. Treat early the diabetes and hit it hard early in the initial stages of diabetes is the motto here. Next slide, please. And at the same time, we give the option of those agents which are particularly safe. And what do you mean by safe? Preventing the hypoglycemia and avoiding SGLT, avoiding the sulfonylurea group of drugs whenever possible. That's pretty important, especially in the initial few years of onset of diabetes. And if you see here, the combination of SGLT2 as well as the DPP4, they it's a good combination in a way because it addresses multiple pathophysiological aspects of the ominous octet. And the SGLT2, as we all know, it predominantly acts at the level of nephron, the kidney, and the glucose toxicity is brought down. The glucose, the glucose urea that happens, and also the pleiotropic benefits in the form of weight improvement as well as the blood pressure gets better. And the DPP4 predominantly acts at the level of duodenum, the incretin effect. It enhances both GIP as well as the GLP-1, and finally the insulin secretion is enhanced and the glucagon secretion is reduced because of the effect of the DPP4 group of drugs. And we at the end want a healthy patient with good glycemia and also the metabolic parameters in the form of the weight, the fatty liver component also should get better and better. So next slide, please. So yes, this particular slide comprehensively addresses the advantages of this particular combination, the SGLT2 and the DPP4. And here we can see the Kaplan-Meier curve. This is from the Declare TIMI 58 trial, the landmark trial, where the dapagliflozin was compared with the placebo, and the primary outcomes as well as the secondary outcomes, wherein the cardiovascular endpoints were clearly demonstrated, and there is a clear advantage with the dapagliflozin, where you can see here the blue line is for the dapagliflozin and the red line is for the placebo. There is a clear separation of these two lines in this Kaplan-Meier curve right from the time when the trial was started, and then the dapagliflozin has relatively lower cardiovascular events in comparison to the placebo, the red line. So the hospitalization with heart failure, there is a clear advantage with this molecule, the dapagliflozin, both primary as well as the secondary prevention can be achieved. And this particular trial also, and also the DAPA HF trial also proved that this molecule can show a significant difference in comparison to the placebo when it comes to the hospitalization with heart failure, and the advantage that this molecule has in the context of diabetes and the cardiovascular disease.
Thank you very much, Dr. Nitin, for an excellent review of the topic cardiovascular disease and diabetes. You made it very clear and very lucid. First, what is the magnitude of the problem, then how the problem is in India, and then the scenario and what we can do about it. There are some questions. I'm sure you like to answer them.
Definitely,
So,
sir.
so the first question is, how does interplay between insulin resistance and endothelial dysfunction contribute to diabetic cardiovascular complications? So the link between insulin resistance and endothelial dysfunction.
Yes. So as we all know, in the previous couple of slides, we were discussing about the insulin resistance and the hyperglycemia in particular. This leads to more and more of inflammatory markers, the TNF alpha as well as the interleukin 1. And the pro-inflammatory markers are on the rise and the anti-inflammatory markers are reduced. And on top of it, whenever there is oxidative stress, and there is a clear demonstration that whenever the peak of the glucose values happen, the oxidative stress definitely increases, and this deadly combination of inflammatory markers along with the oxidative stress will contribute to the atherogenesis and the thrombus effect, and and eventually the cardiovascular event.
Right, thank you. The other question arises is, what are the unique features of atherosclerosis in diabetes and how does it worsen cardiovascular risk? Are the
Yes.
features different than others or in individuals with diabetes?
Yes. So usually, as we all know, the Asian phenotype is something peculiar in comparison to the Caucasian phenotype. Though a person's BMI may resemble the same, but if you compare both the Caucasians as well as the Asians, we as Asians have more of abdominal adiposity, and this abdominal adiposity, you know, when there is obesity and diabetes, the diabesity we call these days, these two parameters, and whenever whenever there is atherogenesis, these diabetes and non-diabetic, the atherogenic profile is different, and a person who has diabetes has a relatively more preponderance to have the atherogenic milieu, and this eventually leads to relatively early onset of cardiovascular event. It can be myocardial infarction, or it can be stroke, or even the peripheral arterial disease. So it happens at a relatively younger age, and not just the cardiovascular events, but also the other complications, the microvascular complications as well. The nephropathy, neuropathy, as well as the retinopathy can happen at a relatively younger age in people who have diabetes in comparison to other person who has the same the atherogenic profile, but diabetes will definitely worsen the combination, and this atherogenic profile is the reason for relatively early onset of the cardiovascular event.
Right, thank you. Two group of drugs which have become very popular these days is one is SGLT2 inhibitors and GLP-1 receptor agonists. So, do these medications improve cardiovascular outcome in diabetics? Why are we keen that every diabetic who has a higher risk of cardiovascular events we be treated with one or both of these drugs, SGLT2 inhibitors and GLP-1 receptor agonists?
Yes. So usually gone are those days where we were treating majority of our diabetic patients with metformin, sulfonylurea group of drugs as well as pioglitazone. But if you see a common difference here, the novel molecule, the SGLT2 as well as the GLP-1 group of drugs, on top of the improvement in the glycemia, these molecules definitely have an impact on the metabolic parameters, which the previous molecules didn't have, the metformin, sulfonylurea, or the pioglitazone. So whenever there is a component, whenever there is a molecule which is addressing the metabolic components, especially the weight, as we all know, overweight or obesity is a state of high inflammation or high inflammatory state. And whenever we address this root cause, which is overweight or obesity, which is again the insulin resistance always depends upon the abdominal adiposity as well as a person being higher in the BMI. So these two molecules are definitely going to address the weight. Of course, SGLT2 group of drugs, there is a robust data wherein close to 2 to 2.5 kilograms of weight loss can happen, and that predominantly is the abdominal adiposity weight that is brought down. So whenever the adipose tissue or adipose weight is brought down, and definitely there is an improvement in the insulin resistance as well, because as we know, adiposity is the root cause for the insulin resistance again. Now these two molecules, and the GLP-1, there is data ranging from 3 kilograms to close to 8 to 10 kilograms as well. But there's few of the patients respond fantastically to the GLP-1. Some few may not, but on an average, around 3 to 4 kilograms is what we can say the weight loss advantage that can happen with GLP-1. So these two molecules stay apart in comparison to other group of drugs, and the weight loss, eventually the insulin resistance getting better and better, and definitely not just glycemia but also because of the other pleiotropic benefits of these two molecules, there is a clear advantage with improving the other coexisting comorbidities of an individual. Maybe fatty liver, it can be PCOD, or it can be sometimes diabetes, and subclinical depression is also well demonstrated. All these parameters can pretty much be brought down because of the change in the phenotype of an individual and not just glycemia.
Now, most of the patients who come to us, we end up writing a medication. But one of the arguments against medication is that we doctors don't give enough diabetes education to patients about lifestyle. So while you are here, can you elaborate on the lifestyle interventions? Can diet and exercise interventions mitigate cardiovascular risk in diabetes, which is very high otherwise?
Yes. So, yes, this is pretty important, not just medicines. And it's important to reiterate the fact that each and every time, whenever the patient is stepping into the OPD, reinforcing the fact that lifestyle management is pretty important, not just the medicines. The idea here is to make sure we achieve the normal BMI, and in this process, we can always bring down the number of meds. It's important to win the trust of the patient. It's always um, uh, um, important to help the patient understand about what is the root cause for the diabetes. In case if a person is overweight or obesity, we should have to make them understand that yes, this is the reason. Of course, there are some non-modifiable risk factors in the form of genetic risk, but the modifiable risk factors, especially the weight, which can pretty much be brought down in case a person is really made aware of these factors. So yes, diet again plays an important role, but it's not just a one-time event, like how patients assume malaria, typhoid, as well as dengue. One, they come, go away in a week or so, and then whenever they come to the OPD for the management of diabetes, some tends to have a person tends to have a molecule or a magical factor which can bring down the diabetes, or kind of a reversal process. Yes, again, reversal is again pretty much doable, but it's always important that instead of using the word reversal, it's important to communicate that it's remission that's we are aiming at, and relapse can pretty much happen anytime. So these days, because of the information being there in the social media, majority of the clients are carried away with the word reversal, and then yes, patients bring back the HbA1c back to 5.5 or 5% with fantastic lifestyle changes. But again, they tend to give a pass the moment they see the HbA1c in 5.5, and they again come back, say after 6 months, with the glucose parameters again going beyond HbA1c going beyond 7%. So it's important to address the fact that it's a discipline that they will have to adhere to for the lifetime, and not just a one-time feat that they achieve. So, and again, reinforcing about the diet and exercise is important. Usually, it is said that 10% of the weight loss helps them to bring back the HbA1c to normal, and the medicines can be lowered but 20% is what is really important to aim at reversal. But again, because of the recent onset of more and more of lean onset diabetes that we usually see, the phenotype, lean phenotype, we can't again convey the same message of 20% weight loss in these individuals. So each and every person is different. Each and every diabetic person is unique, and we'll have to address in a different way for each and every person, and no one size that fits all when it comes to diabetes management in the Indian context.
So, what are the challenges and opportunities for comprehensive CVD risk assessment in diabetic patients within primary care?
Yes, CVD risk factors. Again, yes, diabetes is definitely a CV risk factor. In spite of the fact that there is a diagnosis of diabetes, yes, it's a risk factor. But on top of it, majority of the patients who have diabetes, they usually have one or the other additional coexisting risk factors in the form of family history of early onset of cardiovascular disease, or overweight or obesity, or sometimes smoking history, dyslipidemia, and hypertension. So, um, uh, addressing all these parameters individually, and conveying the patient that it's the total metabolic parameters that will definitely add some value with respect to the cardiovascular event reduction, and not just glycemic parameters. So this um, this way of cardio-renal as well as a metabolic approach, the CARE-ME approach we call cardiac, renal as well as a metabolic approach, is pretty important. And it's important that we also convey the message to the patient. And initial first visit, or first visit of the patient to the OPD, or the first time the patient is being diagnosed with diabetes, it's when we stimulate at that particular point, and when we convey the message quite clear about the importance of the metabolic as well as the phenotype big changes, or the weight and the diet, all put together. The initial first visit, if you convey this message, then definitely eventually on long run, it is both beneficial to the patient, and then the patient will definitely fall back to that particular physician's clinic, because of the fact that there will be results whenever we address the individual coexisting comorbidities along with diabetes, and happy patient and happy physician eventually.
Right, thank you. So, patients who have CVD often also have this diabetic nephropathy. So, how does diabetic nephropathy contribute to cardiovascular morbidity and mortality? And how does this when both of the things are together coming to you? You have CVD also and your nephropathy.
Yeah. So usually, both these nephropathy as well as the cardiovascular disease usually go hand in hand, like how the nephropathy as well as the retinopathy go hand in hand in majority of the clients, majority of the patients. So, one particular factor can also lead to worsening of the other condition. For example, a patient who has chronic renal failure, chronic kidney disease, the probability that he or she can have a cardiovascular event leading to the mortality is pretty high. So it's always important to make sure we screen for this condition proactively. Even though there is no cardiovascular history, we should have to screen with the periodic ECGs, clinical examination, as well as EMT and 2D echo. Whenever we make sure that we are screening the condition proactively, it's important to pick the condition in the early stages, so that we can prevent um, something significant cardiac event from happening. Sometimes cardiac arrest as well. So again, the we all know patients with chronic kidney disease and stage renal disease, majority of them, say 95% of them, they succumb to the cardiovascular event. So again, it's important to make sure, even though the person is absolutely asymptomatic, conveying the message that this is the checklist. Once in every 3 months, once in every 6 months, these are the things that we need to do. And the patient should also have to be stimulated that this is important to to the cost factors that can that the patient incurs because of the hospitalization, because of the cardiovascular event. So these cost factors can be mitigated in case we do aggressive screening right from the beginning, and then we prevent an emergency and subsequent hospitalizations. So it's important that.
Right, thank you. So, let us go to these emerging biomarkers and imaging modalities. So, what are the emerging biomarkers, and imaging modalities for early CVD detection and risk stratification in diabetics.
Yes. So yes, the as we all know, cardiovascular disease again is a high inflammatory state, and whenever a person has diabetes, it's important to, as we routinely do with the ECG, 2D echo, as well as the TMT, it's important to also screen for the inflammatory biomarkers, especially the HSCRP, the high sensitivity CRP, and also whenever a person has any slightest hint of angina, it's important to go ahead with the drop tests, which are quite sensitive in picking the early stages of cardiac ischemia. And also we have multiple wonderful imaging modalities here available these days, especially in the form of the coronary calcium score calculation, which can comprehensively help us understand if a person has high risk or moderate risk of a cardiovascular condition. And it's also important to make sure the ASCD risk calculator is pretty much available these days, and we risk stratify the patient and then go ahead with the statins as part of the primary prevention. And again, the statins dose um, also depends upon the risk stratification when it comes to the cardiovascular risk.
So now three more questions, but in the interest of time, I would request you to just briefly, because these are topics which we can go on and go on discussing. Just
Sure.
briefly mention these questions for the sake of quorum to be completed. Number one, what
Sure.
strategies can be employed for balancing glycemic control and hypoglycemia risk in diabetic patients with established CVD? Another question is, what are the socio-economic factors and disparities in diabetes CVD link, and what are the strategies to address them? And then, uh, what strategies can be used to enhance patient education on diabetes CVD link in primary care? You can go on and on for this thing, but just brief mention so that it seems that at least we have touched these areas.
Yes, definitely. So yes, the hypoglycemia is something which is pretty important. We'll have to choose those agents, especially when a person has an early onset diabetes or walking to the OPD for the first time because of the diagnosis of diabetes. It's important to give them the molecules which do not push towards hypoglycemia, give them the advantage of metformin, DPP-4 as well as SGLT2. And in case sometimes we may require a relatively powerful agent, especially the sulfonylurea or sometimes insulin as well, when a person walks with a HbA1c more than 10%. So it's important to make sure we convey the message pretty clear when it comes to self-monitoring of the blood glucose using a glucometer at home, or these days we can also proactively go ahead with the CGM, the continuous glucose monitoring system, and that also helps them understand where the glucose values are going low, and they can choose, make the wise decisions when it comes to the lifestyle changes as well as the eating habits. And again, the socio-economic disparities. Yes, these days we see diabetes more commonly, both as well as in both in rural as well as urban. As we know, the Asian phenotype, the abdominal adiposity is contributing to this. And again, um, um, the cost is a main factor when it comes to the rural diabetes management. Of course, these days, because of the fact that the patency of the majority of the SGLT2 group of drugs is done, we can definitely give the advantage of these molecules to them. But as GLP-1 is still premium, so choosing the right agent and the right person, taking into consideration the socio-economic factors, is also important. Patient awareness, finally. Yes, it's something more important. Even WHO emphasizes on this part, creating awareness among the patient peer communities, and it's important to make a shared decision making when it comes to an educated patient. It's important to take the views from the patient and then communication, and then making sure that both the patient as well as the physician are on the same page, and that will definitely ensure that the results are much better instead of a monologue between a doctor and and a patient. Thank you, sir.
Thank you. That brings us to the end of this session on cardiovascular disease and diabetes. And Dr. Nitin, thank you very much. You covered all the aspects in the stipulated time. Uh, so, with this, I hand over the podium screen back to the organizer.